My name's Tim Johnson and I'm a consultant in pain management at Hope Hospital in Salford. We have a Manikin here which was conceived and developed with the aim of improving training of junior doctors who have to do nerve blocks on patients, particularly related to chronic pain where they may be injecting into and around the spine. Juniors often come and part of their training is that they have some experience of these blocks. However, apart from practicing on patients, it's very difficult to give them that kind of experience. I'm going to put my finger into the oral cavity because it's very important when you're doing this in a patient that the needle doesn't go through the oral cavity. And then by advancing the needle in that direction that we've decided, I'm looking in this plane, aiming for the middle of the zygomatic arch, and in the AP plane, aiming for the pupil. And by advancing the needle, it's usually possible to identify the foramen ovale. What I'm going to do is just demonstrate without X-ray here to start with the principle of doing a lumbar sympathetic block, and bear in mind these were all done without X-ray control originally. We use X-ray to find the vertebral level of L3, which is where we're going to do the sympathectomy, and I'm going to do a right sympathectomy, so that's from that side. One of the things to remember is the right and the left are the opposite way around when patients are upside down. So yeah. That takes a little bit of getting used to. And usually the landmarks are to find the spinous process and then to go a hand's breadth away and insert the needle at about 45 degrees. So if I were to do that, and again, this would be an uncomfortable thing to do with local anaesthetic in an awake patient. So the needle's going in about 45 degrees, and the front of the lumbar spine is actually quite an anterior structure, and it does look as if that needle's going in an awfully long way, awfully deep, and it's going to make contact with the lumbar spine. The thing it may hit in the meantime is the transverse process, which we were looking at before. And sometimes it's necessary to manoeuvre around the transverse process, and you can see that quite clearly on the X-ray. So we've now got L3 is smack in the middle. We know it's L3 because none of the two vertebrae on each side haven't got ribs attached, the top ones anyway, so it must be L1, 2, and 3 is now in the centre of the field. Okay? Yeah. So would you like to carry on and do the needle placement for lumbar sympathectomy? Obviously we're not using local anaesthetic at the moment. What you may find, well, one of the first things to do is to identify which side we're on. So you might use just a marker to identify, first of all, on the screen, which is right and which is left. Okay, so, okay, screen again. Okay, so you've actually got it with the X-ray view is the same way round as you've got it in real life, which is very convenient because you can obviously do a horizontal shift. That's the facet joint, and that's your needle now going down onto the pedicle there. So it needs to be aimed further headwards.